So just before we send it over to the cadaver lab, I thought it was important that we do some level setting because I'm going to be talking about a technology that is part of the everything cool in spine. It's not robotics, it's not navigation, but it leverages our own proprietary camera technology and intelligent software for use in spinal applications. So the first question always with the various technologies we have at our disposal, why would we do this? Why are we going to invest industry's money, personal investment into creating a new technology? We want to understand the problem. So when we looked at this in spine in general, we noticed several things. This is going back 7 or 8 years ago. The ultimate goal of trying to visualize your patient's anatomy is really getting to an axial view. How do you see your tools as they move in real time to your patient anatomy while they're on the table, and also what happens if that patient is moving? How do you react in real time to those situations in the OR? We found that what existed and what exists today, there were several barriers to overcome. There was too much radiation being used intraoperatively, challenging workflows when we're trying to have additive technologies, improve surgical workflows. We don't want to be adding time to a procedure. We want to be saving time. Too expensive. We just didn't believe it should cost over $1 million to instrument the spine. And then some accuracy concerns with how registration has been occurring since navigation came on the market. This idea of averaging across multiple levels, inducing accuracy concerns. So we saw these as an opportunity for innovation and creating the cool with everything cool in spine and a new vision for what navigation can be. You heard me mention in the beginning that we use camera technology and intelligent software, and in particular, we use something called machine vision. This is not exactly a consumer level phrase yet, but I guarantee you everyone in this room knows what machine vision is. It's the same technology used in self-driving vehicles. On the left-hand side there, in the Tesla, there are cameras around the car that are continuously interrogating the surroundings, identifying things like speed, signs, pedestrians crossing the road. And we thought, could we translate that to medicine? Could we reproduce the 3D imaging system that we have and also reproduce the years of fuzzy logic we have, the intelligence software our own brains create? So on the right-hand side here, what you see is our 3D imaging system, which, by the way, uses only visible light, the same light that is happening inside of this room here, so we do not require any LEDs. And rather than looking for that pedestrian crossing the road or the speed sign, we are automatically identifying anatomical features. What is bone? What is soft tissue? What is the lamina? What is the spinous process? And that takes registration times from tens of minutes of setup in the operating room down to just tens of seconds. And when we shift over to the lab, you're going to see our entire workflow. So we didn't do any pre-setup. It's all going to be live on the demand and to see how this works intraoperatively. When it comes to the system, we have the core technology, which also includes surgical light, so providing more value to the procedure while you're in the operating room. We also have cameras in those surgical lights, which means you can leave them on when you're not using navigation as a medium to low exoport type functionality. So getting more functionality out of one piece of equipment in the operating room. We're going to focus in the lab today on spine, but we have the full percutaneous MIS package. We also have applications in cranial and the entire suite of tools that you would need to use for any navigated spine space. And we are vendor neutral. So even though we'd love it if you use our C-spine instrumentation, we can work as eloquently with Globus instrumentation, Medtronic, or any of the competitors on the market, which makes it very valuable in a hospital ecosystem. We don't have to get everyone on the same page because everyone can use the technology. Thinking about planning, we spoke a fair bit about planning in various conversations today. We have the planning aspect also to reduce that cognitive load during the procedure. Some of our surgeons plan this a priori, others plan it intraoperatively, and you'll see some of that in the operating room. Full functionality, and when we're thinking of that continuum of care, on the right-hand side, we're also thinking about providing imaging when it comes to orthobiologics. For example, the insertion of orthobiologic pellets using facet fusion approaches. So really trying to think about how do we create this entire ecosystem throughout the entire aspect of the procedure. talking about what we've done clinically with the technology, and we are installed in just about 100 hospitals already, so we're growing extremely fast. Everything from major teaching luminaires to 1 to 2 busy private practice hospitals, and you'll see today, Dr. Larson has his unit in his ambulatory center. So here we're showing the reduction of radiation over 96% reduced because we use visible light. That is our main approach to registration intraoperatively. Because of the speed of registration, which you'll see in real time as well, we have a study coming out of Singapore in a pediatric site. We're reducing blood loss by 44%. That's compared to their existing standard of care, which is freehand and fluoro guidance. In another study that will be coming out in the coming months, from the workflow time, skin to skin. Typically, when you're putting in technologies, you're just hoping you're not making it worse for the surgeon by adding tens of minutes. Well, we're finding, because of the speed, we're in that study coming out of Texas, on average, skin-to-skin and pediatric deformity, we're reducing procedures by 63.6 minutes. Very, very significant savings intraoperatively with that blood loss. And when we think about the actual registration time, I don't have one comparison to a robotics here, but on the far left there, 41 seconds, that's clinical average. From when you want to navigate until you can navigate with no intraoperative setup, down to the far right when we do the intraoperative CT-based, taking about 15 times longer. So everything we're focusing on, and when we transition this over here, is we're really workflow. How do we try to improve clinical workflow while helping all of our surgeons get those results they're looking for their patients? So we'll pass it over to the cadaver lab, and hopefully someone is over there. Perfect. I think we're ready, Dr. Larson.
Can you see me and hear me?
Yes.
Hi, everybody. I'm Jeff Larson, and as Beau said, I use 7D in my ambulatory surgery center, and a variety of reasons that I navigate or gone to 7D are manyfold, but the number one reason for me, or at least a high first, is this is what I look like under my surgical wear. I don't wear lead. There is 0 radiation for this device. It's accurate, it's fast, and for me, it's very cost effective. As I mentioned, I'm in an ambulatory surgery center. My whole unit was less than $500,000. I had a payout for it and such, but it's very, very cost effective. As far as my workflow, which is very important, the only thing I've done ahead of time is I've done a dissection. I've done a 6-centimeter incision to expose 3 levels, much less for 1 level, but I've exposed 3 levels so that you all can participate if you want to come in here and put in some screws. When you look at this dissection, you can see one of my most important instruments is this Bovie. And as Beau mentioned, this is machine vision technology. So it needs to see the bony anatomy, the nooks and crannies, the little nuances that was present on that preoperative CT scan. And speaking of preoperative CT scans, any thin slice CT scan will work. So I'm in the Idaho Panhandle. Patients come from a distance. If they've had a CT scan, I can just load it onto my machine without having them get a dedicated CT scan for some other reason. So we can use the existing CT scan or get one. I do a very meticulous dissection, become known to have like a 0 blood loss situation because of that meticulous dissection. And quite frankly, every patient in my surgery center goes home that day. Nobody stays overnight. I feel like they're much safer in a hotel where I could attend to them in the emergency room of a bona fide trauma hospital if I needed, and knock on wood, that hasn't happened. But the meticulous dissection with Bovie also, I think, deadens the periosteum, possibly, just a little gestalt there. So I've done the dissection, and the next thing we're going to do is we're going to register what I have exposed here to the preoperative CTs that's loaded onto the workstation. This is the fiducial array. I like things to be trimline and out of my way. And so I put a little stab wound below my incision, like a little blowhole. It's become known as the blowhole of Larson. And I'll attach this to the spinous process of S1. And when you're working in a lumbar spine, if you're working from the left side patient and you're right-handed, I like the array low, because all of your screw angles seem to be like this. If I'm working in the cervical spine, I like the array high because you're working in that angle. So the fiducial array is here, and now those same Tesla lights or cameras that Beau spoke of happen to be in the best OR light you will ever use. Those cameras are up here. This light is going to do what's the flash navigation. And I want to make a point here that you see everything that's in my room. There's no entourage. I have my surgery tech, Gary, today, and I have Alex, my nurse. There's no radiation tech. There's no radiologist. I don't come into the room and dread it when I see like the new student technician that's going to do my 30 images to register, what I need to register. This is all done here. So I've exposed my area of interest, and I'm going to have, please turn on the little laser lights. It has a little kind of some sights, and I'm going to aim it. I'm going to put in the screw in L4 and leave 5 and 1 for you guys if you'd like. So it's aiming at 4 right now. I'll let it stop shaking for a moment. I can control the whole thing from my screen. I'm going to flash. So what you're going to see is light's going to flash in, it's going to ricochet up, and we're going to gather 1 million points of data. It's flashing, gathering the data. It's collected it, and now it sees everything here. I'm going to hone it in. It doesn't have to be like perfectly honed in, but I'm going to hone it in. At this point, I'm doing segmental. So if I was doing cervical spine stuff, I'd do a segmental. Normally in a lumbar, I might do a block registration of L4 and L5 together, or L4 and L5 in one. But here I'm going to hone it into a segmental registration of L4. So first point is the lamina of L4, and I can do this myself, or you can hit it, Alex. Tip of the spinous process of L4, and the kind of the lamina right there. Ready? So I wanted it to not work, but it did work, because you can also like move this around to like see it better, but it worked. Okay, so take this out of the way. I'm going to go ahead and press my left foot to navigate. I'm sorry, I'm registering it right there. It's doing it. There you go. Green, that's what we want to see. That's a absolutely fabulous. There's 1 million or even 1 billion points of data in this one here, probably. There's so much, right? So now I'm going to test my position here. Spinous process. And the spinous process is as important as the facet or the pedicle or the transverse process to the knowledge of the machine. There is so much real estate on the spinous processes, so I really denude those. I mean, if you guys had a steak with me last night at the steakhouse, you saw how that bone went back, right, guys? And it was clean, and that's how it is here. It's a clean exposure to the spinous processes because there's so much bone there. So let's see. We got the spinous process. We have the lamina. And in this case, let me do a cortical screw at L4. So let's just see, the pedicle, to my knowledge, would be about right here. I'm going to move this out of my way a little bit so I can bring it in. And there we are. And we did some, I don't use the preoperative screw planning that I'm doing for you here today. I like to plan on the fly. That's another thing about this. I get to call audibles all day long or all 2 hours long in my OR with this. I can do that. But here I kind of see where I want to have my pedicle entry point for a cortical screw. So I'd like a navigated burr, and I'll take it, we'll accept this. So go ahead and accept it. We haven't already. So I like a navigated burr. I'm not navigating with it now, but I will. I like the burr. That's a great spot for a cortical screw. I'm going to put a little entry hole there. I like it. I'm going to take a fixed gear shift, if you will, put it in that hole, and we like that too, and I'm going to kind of aim exactly where I want that baby to be. How's that look? We'll take it. He just threw a virtual K-wire in there. We'll go ahead and do. Okay, so this, I like to size go ahead and flip you can see the size of the pedicle, 6, 5, or 4. I'll take a 6, 5 there. As far as my length, we can throw a screw on there if I want to. This is a 6, 5, what is it, 40? 6, 5, 45, perfect. Okay, give me a virtual K-wire, please. Just tap this right there. I'm gonna take this out now, and we have what's called a virtual K-wire. So I'm going to just take the tap here. The tap is navigated, but if I had it unnavigated, like any other instrument I might have, what I'm going to do is you can see on the bottom of the screen these K-wires. So I'm just going to line it up. And then if I put my navigation in, kind of lined right up. So I'll go ahead and tap. Take it out. I'll take my feeler, any kind of feeler, if I have it. I like to feel. And it's, you know, bouncing off we're in there, it's all in there. I typically will do my screw holes before I put my screws in, because if ever I need to re-register or something like this happens, what happens here, you got to call x-ray, you know, here I am wobbling it around. No need, in fact, I'll take it out and move it. Watch this. Hey, disaster, right? Call the radiology tech. Nope. I'm going to hit flash fix. What's happening here? It's going to flash again, and it remembers everything we did before with our registration. Is it doing it now or no? Is it good? Oh, I'm sorry. Yeah, you got to re-aim it. I'm sorry. There's these little lasers here, so let's go ahead and aim it. Drop it there. Flash fix. Oh, you do it? And you can do this all day long if you want to move it to another point or somebody hits it.
Jeff, I have a question while we're waiting for that. Can you just clamp it to a spinous process you see inside that wound instead of having the small?
That's what I just did. I clamped it to a spinous process. Is it visible? Flash fix not working. What is going on here?
Dr. Larson, you have to put the frame on the spinous process of interest.
On the end? Well, I can put it anywhere actually, right? Where it was. Oh, I gotta be on. It's gotta see it. There you go. Just a moment. Okay.
And we can show this feature in the walk around afterwards as well.
I mean, it's quite compelling. This is Martin Pham, by the way. Not needing to wear lead, not having the C-arm in the way, workstation in the way. I was certainly wearing more pounds when I was in there than you are right now. And the question I have is, do you need to flash with each segment, or is it just you don't have to, but it's recommended because you're working down different segments, or what's the workflow as you instrument the exposed spine?
I usually do a block registration, so I'll do L4, L5, or L5S1, and then if I go to do the third level, maybe I'll do a new flash.
And typically,
what this done for me, what this has done for me is I started doing this. We got it fixed. So we just did a flash fix. Okay, I guess I put it on the same spinous process it was on before, so it was in proximity. I don't know if that's key or not, but here we are down that same hole.
and so for a deformity
So without having to
case,
do there we are down that exact same hole. So the accuracy is incredible. And what this has done for me is through this incision. I mean, at first I was doing a single level. 4/5s or something like this. Then I switched to 2 levels because really, sacrum's right down here. And really, L3 is right up here. And it's so easy and open. So this has expanded my practice significantly at the Ambulatory Surgery Center. It's fast, 0 radiation, it's accurate, and you can use it up and down the spine. I do cervical, I do posterior cervicals it's all posterior, it's all posterior, just like the bunch of these things. But I do posterior cervicals up to 3 levels. I do lumbar up to 3 levels. Everybody home that day for other reasons. It's the whole start to finish performance-based practice. It starts in the office with selection of the patient. And I've got 70 and 80-year-olds as well that are having surgery. I'm not just seeing.
I don't know if they can hear us in there from this mic, but to answer the question about if we think of a longer construct, because we've had massive uptake in all deformity procedures, and if we're doing a 10, 12, 15 level, typically it's usually a block of 3. And because the speed with which you can register, and we're not having to do 2D, 3D merge, it's just move that clamp up, press the flash, instrument your 3 levels, and then move up your spine throughout the entire construct that way.
I've seen on one of your slides.
My back, Beau?
Yep, we can hear you now.
Yeah, so let's do another thing. Let's just do a real quick one here. Let's go ahead and do L4, a traditional screw. I probably have enough exposure here to do that in this case. If I come over here, that's pretty good right there for a traditional screw. So I'll go ahead and make my little...
Yeah.
And as far as track tools, we have cervical drill guides,
pretty good right
lumbar
there.
drill guides. Any tool you need for your procedures there's a tracked version of it with the system. And we can also attach arrays to any of your existing infrastructure as well.
Does the system come with a TV? Do you have to use the screens that your OR has?
So it's all a combined
Virtual
unit.
K-wire?
You can port it out to the screens in the operating room as well.
Need that.
So it comes with a surgeon user monitor. That's where Dr. Larson is looking at and where we're getting
go off
this
the
feed
virtual
from.
K-wire first.
There's a
Might as well
like
match it
nurse
with
monitor,
this.
and then it can be outputted to any other aspect. Any other monitor.
And what's the adaptation for the MIS? Do you use it like a perk pin or like what?
Yeah, great question. So
like that.
for the perk, we have no access to visualize that bone.
Right.
And so what we use is we use a iliac pin, similar to what we've seen today, and we have a unique 3-dimensional shape that we put on the surface of the patient's back.
Okay.
That we take an image with our 3D
bring it
imaging
up,
system. We use an
drop down.
intraoperative scan and it merges the two. I do have a really nice animation that I can show in the lab that shows the entire workflow. But it uses the same imaging hardware, same tools, and it's a different module when you load it up, just like your phone. The apps are perk,
Let me see the
open,
screw on
cranial.
the trajectory.
So then when you
Put the screw on it.
re-register, you're flashing off the grid on the skin.
That unique 3-dimensional shape.
What are you doing?
And that works for thoracic and cervical too, or is that mostly just for lumbar?
No, that's not.
So for perk, we have that a different clamp that can be used in the thoracic region or in the cervical region as well. Okay. I think that probably drives home the point. So, I think we just did 4 or 5 registrations in a couple of seconds. And we'll see if there are any other questions. Please come by to check it out in person. And as we mentioned, we left quite a bit of anatomy untouched, so you can use it right from turning on the system to instrumenting without trying to
me say one more-
hide any
may I
of the
say one more
registration in the background.
May I have one more word? May I have some more?
Go ahead.
One thing that I really appreciate about this, and I have the Excelsius GPS system at the hospital. I don't have this at the hospital. I'm not getting Christmas cards from the hospital right now because I pretty much shifted everything to the outpatient surgery center, and I don't know that I'm going to get one of these, but it would be like a phenomenal tool for a C12, which is always a white knuckle case for us. It is it's easy. It's there's no absence of the entourage and the difficulties that could come with that. The intelligence gets put back into you, the user. And I treat it like I'm a conductor in an orchestra, a symphony orchestra, and it's just like another sweet violin because you can use it to see how much decompression you did. You can see if you really got that bone spur off. If you're trying to take something out, you can do much, much more than just place a screw with it. So it's been very successful. I'd be happy to entertain any questions, and you're all welcome to visit me at our surgery center. At my surgery center, you're allowed to come in and you're allowed to scrub and you're allowed to get hands-on with the patients, and my patients will agree to it, and or not, I guess. But I welcome you to that as well. So it's been good for me, and I think you might enjoy seeing it. Thank you.
Yeah, simple question. Simple question. Can you hear us out there? I want to ask, how much width do you minimally need? So
the retractor system that I use, they don't have here. It's almost like the type you use in a cervical spine. the,
McCullough.
yeah, no, it's basically a crank.
do
You don't need this much. No, you
You
just
don't
need.
need to see the whole facet joint?
No, no, no. You need, that's what I was saying. You really don't need to expose as much bone as I have here. You
So
need.
you have about a 3-inch width exposure. Can you get it 2, or what is it that you really need to see enough relief of the morphology?
I guess to put it into, what converted me to this procedure is when I put a Coflex in at my surgery center, I was like, wow, if I can do this, I can do corticals with this navigation system. About that much exposure. You need to see the lamina and the spinous process. But you need to save the spinous processes for the exposure because you want that for your registration. And when you give that spinous process to your tech, you've got phenomenal clean bone graft.
All right, great. Thank you very much.
Thank you.
Excellent.
Thank you.